Okay, the last thing we're going to look at here now, if you follow along on the sheet, is a neurological exam. And what you do want to do now is you want to assess for reflex changes. And again, these will be very important in radicular type encroachment lesions of the cervical spine. Okay, relax. So what the reflexes that I like to test are the biceps, the triceps, and the radioperiosteum. Now, when you do these, we're usually taught to do them in this fashion, where you just find that long-handled biceps, and you tap it, and you get your biceps reflex, and then you can come out here and get your triceps reflex. And these reflexes are relevant only if they're asymmetrical. Many patients, in fact, more often than not, you won't find reflex at all, but you can usually find it if you reinforce, and we'll do a little bit of that. However, you're looking for asymmetry. That's what you're looking for. I find the best way to test these is just to have the patient relax the arm on a pillow, find a tendon with your index finger, and then just tap on your index finger. And you can see with Julie, she's a little hyperactive. She has hyperactive reflexes, and then with the triceps, you leave them right where they are. You just find the tendons right above the olecranon. You tap it, and you look for the movement of the muscle. And again, all you need to do then is to test the other side. Well, look at that. Almost the same as that side, about. And the same with that reflex. And then the radioperiosteum, which I think is C8, you'll have to look that up. But I also test the radioperiosteum. And you do that just proximal to the styloid here, and you just tap the bone, the radioperiosteum, and you usually get a biceps type reflex. So those are the three reflexes that I test in the upper extremity. Now, if you are dealing, if in your screen exam, in your history, the patient complained of dizziness, anything that would resemble upper motor neuron, then you need to also check for pathological reflexes in the upper extremity, which would be like the Hoffman test, where you flick the thumbnail and you get a response from that. What else? You remember? There are other upper motor neuron tests here. One of the things is, I just remembered, is clonus. Now, clonus is abnormal, either in the wrist relax, and we have seen this with Julie at times because she had meningitis, and when she actively had meningitis, she had sustained clonus, I think in her wrist and her ankle. Yeah. But she doesn't have that anymore. But that's an upper motor neuron sign too. But there are other upper motor neuron signs, and you definitely, you don't want to be treating someone's neck that has upper motor neuron signs, because that's not where the problem is. And we don't treat those problems generally. Okay, so you check for your reflexes, and you can also do your pinprick test and see if there's sensory changes, paresthesias in certain dermatomes, like that. Okay, so that is your upper quarter screen. Did I forget anything? Now, beyond this, now we're looking at a problem somewhere in the upper quarter where you're going to examine in detail, and we are going to talk about specific exams of the neck and of the shoulder, and we're going to do the shoulder again right now, real quickly, to show you the shoulder exam, which is listed right here on your handout. Okay? Okay, Julie, now I'm going to get you back over there for a shoulder exam. Stand up.
Okay.
Yeah. Well, that's just about right. Look like Porter.
Do I? Yeah, because my hair is
The white
long.
hair, yeah.
Yeah.
Okay. All right. Now, we did active elevation of the shoulder in our screen exam. We found a positive finding. They had pain. Now we want to do that a little bit more specifically, and find out where the pain is and when it comes and goes and that kind of thing. So use this arm and lift it, and take it up over your head. Tell me if you have pain.
No.
Okay, put it down. Okay. Now, in our screen exam, she did have pain up in
I
here.
had tightness.
She had tightness up in there, which is, many times on a trivial problem, you have to explore that tightness because it may be pain. So that's active elevation. And if you suspect an arc of pain, you should pursue it in a more aggressive fashion when you get into the shoulder exam. Normally, an arc of pain will look like it hurts, and now it hurts again. Now, she had a little discomfort up here, but she didn't actually have pain in the middle of the arc, which is an arc of pain. But we could try to create that by introducing the inappropriate rotation. Now, in the shoulder presentation, you know from that when you elevate, and what Cyriax says is that when you bring the arm up in abduction, the greater tubercle approaches the acromion at about 70 degrees. At 80 degrees, it lies directly underneath it, and then at 90 degrees, it starts going down away from it. And that's his characterization of arc of pain, because you come up and the greater tubercle's got to get underneath the acromion, and then you can go on up. So if you can create some congestion in there, you may be able to create an arc of pain. And a created arc of pain is an arc of pain, whether it's created or not, because in normal shoulder movements, even if you do the wrong thing mechanically to create more congestion, it doesn't hurt. But with a problem in the shoulder, it does hurt. So let's see if she has an arc of pain. Now, we'll have her abduct in the wrong rotation. So if we have her abduct with her little finger and come out here, and she may have an arc. Any problem?
No.
Nothing? Okay, put it down. All right.
Is that also the empty can test?
No.
Okay, that's different.
No, this is, what we're doing here is
creating
we're jamming that greater tubercle underneath the acromion where it doesn't belong. It belongs back here, because when we do abduction, we got to get external rotation. So if we introduce internal rotation, we're going to introduce more congestion. So now the interesting part about Julie's surgery is that she ripped her biceps up pretty well when she dislocated. And another interesting finding here that I don't think I covered under rotator cuff tendonitis is that 1 out of 7 biceps are involved in all rotator cuff surgeries. So Neer, when he did his surgical observations and need for surgeries, when they explored the rotator cuff and found a tear in the cuff, they also found in 1 out of 7 cases the biceps tendon was also ruptured or attenuated. And Julie's was attenuated severely with her dislocation. So we can look at the biceps a little bit on arc of pain, because in flexion, you have to have internal rotation, and it takes the biceps out of the equation in terms of getting it underneath the acromion. But if you do flexion and external rotation, the biceps is going to get caught until you internally rotate. So that's what I'm going to try to have her do, is to lift your arm up in flexion. Now, does that hurt you?
No.
Well, she's loosened up that. She's totally negative, which is nice.
Okay, good.
Because she has a bicep. I don't know what he did with her biceps.
It was split into, one part was over here, one part was over
He
here.
probably put it back together, I
Yeah.
assume. I don't know, but at any rate, I would suspect an arc of pain here with the biceps tendon if there was a problem there. Obviously, we're going to be dealing with a pretty good result here with the surgery. Okay, so that's active elevation, and we're looking for where the pain is, the localization of the pain. And with active elevation of the shoulder, we look for localization of the pain. Is the pain here? Is it here? Is it somewhere else in the arm? Okay? the willingness of the patient to move it, and she's very willing to move it. And then once we see a limitation in active movement, we can take that further and passively move it further, so that if she has, if she has pain, or let's say she has active movement to here, well, that's abnormal, and it may not move any further. But we would like to know at this point in time, we'll document this on passive movement testing, but we'd like to know if it will actually move further, or it may only move like right to here. Now, like in Patty, the patient you saw with the neck stabbing, she really could only move her arm about to here, but I could take it all the way up. So if there's a difference between active and passive movement, that's a bad thing. Because if you can move it passively more than they can move it actively, that means that you've either got a neurological problem or you've got a severe tear. That there's just not enough continuity there for the tendon to bring it all the way up into the full movement. Either way, it's bad. And you don't like to see that. And many times with comparing active and passive movement, you would get what we call a drop test, so that if you can take them to here, but they can't hold it, you let go and the arm just falls down because it can't hold it there. So that's comparing active and passive movement. The main thing, though, on elevation, the main testing that you're doing here is you're looking for arc of pain. And if there's no arc of pain here, then generally speaking, that rules out 6 tissues, right? The 6 tissues of the suprahumeral joint. So no arc of pain. And classically, with a adhesive capsulitis or problem like that, or an AC or SC joint problem, you won't have an arc of pain. You'll just have a limitation of motion. And with a frozen shoulder, they'll only live so far. Now, the other thing that you look at in active movement testing of the shoulder is rhythm. Rhythm is extremely important in the shoulder. Now, Codman is the author of the 2-to-1 ratio, and I'm not sure whether he's right or not. You know, Syriax talks about the 70-80-90 rule. There are many studies done that show a difference in rhythm, and the rhythm we're talking about is the amount of movement divided between the glenohumeral joint and the scapulothoracic joint, so that you have 180 degrees of movement. And normally with Codman, he divided that into 60 degrees of scapular rotation and 120 degrees of glenohumeral movement. So with Codman in the 2-to-1 ratio, it's smooth. And it's really good, because it will many times tell you exactly where the problem is based on the disturbance of the rhythm. Okay? If the problem is in the glenohumeral joint, they don't want to move the glenohumeral joint. They don't mind moving the scapulothoracic joint, but that causes a disturbance in rhythm, so that with a frozen shoulder, they'll give you this stuff right away. They rotate that scapula because they don't want to rotate their glenohumeral, so they rotate the scapula, and then they'll give you what they got with the glenohumeral movement and the suprahumeral movement. That can also occur in rotator cuff, where they don't want to do this, but they don't mind doing this. Conversely, with a AC or SC joint problem, they don't want to rotate the scapula, so they'll get this. And like we showed you with Patty, the girl on the slide, she could do this. She couldn't rotate the scapula, so she had a very severe interruption in rhythm, whereas the rhythm was not anywhere near 2-to-1. It was all glenohumeral, and then whatever she could get scapular. And what happened with her, of course, is she actually derotated, because she couldn't even hold the scapula at a normal point to get 120 degrees of abduction. The only way she would ever be able to do that would be if they would fuse her scapula here. And that's the only treatment that would work with her, would be a fusion of the scapula. And if they fuse the scapula here, then she could work up to 120 degrees. She couldn't go any further than that, because the scapula wouldn't rotate, but she could get function that way. So the surgery on her would be indicated, in all likelihood, just to give her function up to here. because she could get 120 if you just stabilize the scapula. Whereas what she's dealing with now, she gets her 120 and then she derotates about 20 or 30 degrees, so she's only getting maybe 60 or 70 degrees of elevation, and that is not functional. But what we're talking about is rhythm. So as you see the patient from the behind, now which is your bad arm? Yeah, you just take it over your head. And you can see a normal rotation, and take it up forward and flexion, take it flexion. And you see this going normally, see a normal rhythm between the scapula and the humerus. So that's rhythm. And again, if there's a problem in the AC joint, or the SC joint, or the scapulothoracic joint, what you're going to see is a disturbance in rhythm favoring the glenohumeral and suprahumeral joint. When you have glenohumeral problems, then you'll see a favoring of the scapulothoracic joint in terms of rhythm. Okay, so these are the things you look for on active elevation of the shoulder. Okay. Going along with your let me see, Julie. I know we did some of this on the exam, so we're not going to do it again.
Okay.
Okay, we did passive elevation. Now remember, I showed you in the shoulder part of the presentation how you cross your hands so that you get an infield. But you are doing, when you do passive movement testing, you're looking at range and infield. And so we did that already pretty good, and we did all the passive movement testings, and we also did the resisted movement testing. So I don't think we're going to do that again because of time. But by the time you're done with this in your shoulder exam, you should know what's going on, and it's right here. And then beyond this handout, I'm also going to give you a handout that I use in my clinic that is just for the shoulder itself. And this is what it looks like. And again, this is my worksheet I take into the room with me. And the worksheet goes over all these things that we did in our shoulder exam at the end of our screen. The only thing it doesn't do is that at the end of resisted testing, we have some accessory tests. And I do want to go over those a little bit at this time. We'll do the Jobe test, the impingement test, and the De Palma test. The Jobe test, if you are suspecting a rotator cuff problem, again, we do know from what I told you before that rotator cuffs pretty much center around the supraspinatus, okay? So that you can put a lot of stress on the supraspinatus using the Jobe test. That is the empty can test. So that when is this the bad one? Okay, so the empty can test is done in the plane of the scapula, which is right here. And it's you take it up, you empty the can, so the thumb is down. And then that particular movement, relax now, requires, if you do EMG testing, requires more activity of the supraspinatus than any other muscle in the shoulder girdle, just from doing it this way. So now we can test that muscle, hold it tight. Now, you have to be really careful on this test, because a lot of times, even if you don't have an arc of pain and you don't have any other positive findings, this test hurts. And it's again, a supplemental test to clear up the tissue involved here. And if the supraspinatus has any kind of a problem in it, this usually hurts. It hurts just to hold it there. And then if it doesn't hurt to hold it there, then you can have them do a resistive test, and you must be very careful when you do this so that you don't hurt them too much. And what I usually tell them is that if you feel any pain, just stop. And so I'll just put my finger on here and I'll just say push up against my finger, now relax. And did that hurt?
Yeah.
That's good.
Good.
Yeah, because that means your supraspinatus is probably really getting stronger.
Good.
Okay, good. She had to get a lot of repair done there because she ripped everything up pretty good. Okay, so that's a good supraspinatus test to differentiate one tissue from another tissue. Now the other thing, the biceps tendon can be stressed in many tests also. You can see a lot of these special tests, you can find them in Hoppenfeld and a lot of your orthopedic manuals, and you may want to use what you really feel comfortable with. But before we get to biceps, let's stay up with the cuff a little bit here. And with the cuff congestion type tests, because sometimes you know, subdeltoid bursitis is an entity. It's very rare to see, but it is an entity. And whenever you're dealing with the subdeltoid bursa, you're dealing with a congestion problem. You're dealing with what we call impingement, which is that area of abduction where it gets caught underneath the acromion. You can stress that particular tissue with the Kennedy-Hawkins impingement test, which is bringing it to here. Relax now, Julie. You bring it to 90 degrees and neutral abduction, adduction, and then you rotate it down. Relax now. Does that hurt?
No.
It used to. Remember, it used to.
Yeah.
She's a lot better. No, I'm going to get over here right and test it, but relax now, Julie. And you're looking for pain here. And that usually, that's your Kennedy-Hawkins impingement test. The near impingement test, of course, is the best one, where he just puts an anesthetic in the suprahumeral area and then does all these tests and nothing happens. It doesn't hurt him. And so that's pretty definitive. Of course, we don't do injections. Now, on to the biceps, the long head of the biceps. The long head of the biceps is the primary shoulder flexor, okay, in external rotation. So if you have them hold this position, if there's a biceps problem, many times that will hurt, okay? Now, to further stretch the biceps here, and same as the supraspinatus, if you give them resistance, and be careful.
Okay.
All right, now I want you to lift up and relax. And usually you just have to put your finger on the palm. You know, try to lift up. That's it. Because with this long lever, you can overcome that biceps. Okay, so if they have pain on that, then that would be an indication of biceps. Now, De Palma took it one step further, and what he did was, because he knew what was happening with the tendon, when you extend, the biceps is a flexor. So if you extend it, you put it on a stretch, okay? Now bend your elbow up your back. Now really, don't do it yet. If you
rotation?
Yes, that's what we're going to do. Now down, just relax.
Okay.
Let me have it. You have them, you extend it, and then you put it up their back, and you hold it right there. Now that doesn't hurt, right?
Right.
Okay, so what you do is you come in behind them, take that wrist so you can grab it, and now don't do it real hard, honey. But
Okay.
just try to pull up a little bit.
Pull up?
I want you to pull up to your bra strap.
Okay.
And relax. Does that hurt?
No.
That's wonderful.
Good.
Okay, now what is happening here is the biceps, what happened to my bones? The biceps is put on a severe mechanical disadvantage when you do that. You can turn around, Julie. When you internally rotate them and extend them, and then try to bend that elbow up, you put the biceps on a severe right angle strain over the lesser tubercle, right where it invaginates to go into the glenohumeral capsule. So in that particular stress mode, if there's a problem there, that will hurt. So you're looking for pain in that particular. Those are accessory tests. The drop test is an accessory test also, but those are the main ones that I use.
Test internal and external rotation strength at this point. We didn't do that on the upper quarter screens. We're doing that during the shoulders.
We did it. Remember we did it the other day?
The other day.
Yeah, we did it the other day. Remember I held you in tight? Yeah.
I was just
Yeah,
trying to
yeah,
put it all
we do.
together.
Yeah, this is just this is simply an augment of what we already did in the clinic where we were examining Julie, but I couldn't remember exactly whether we did everything that I wanted to have done here. But this is my shoulder worksheet. Again, it'll be in your packet. Has a body chart on it so you can mark the pain and so forth. So that's the upper quarter screen and the shoulder. So now we'll put it on stop. Just press it.